Hello, and once again, welcome to another edition of the Osteopathic Lyceum podcast. Once again, going to go through some historical material in order to once again attempt to show where the approach that I take to the profession is generated from. One of the things that you're looking for, or one of the things that is useful to find when looking at previously written documents, whatever purpose they may have been written for, is things that are exceptionally similar. So you're looking for themes. You could say that you're looking for phenomena, consistency, what is the same, different terms. Essentially, you're looking for the stuff that's the same. I've heard it and I've said it as the golden thread. What unites these things, the thing that unites these things would be the theme. The theme could then be termed a construct. So this is consistently present, maybe in different words, but it's the same thing, the same phenomenon present in all of these. So you can then call it construct. You could then you could then implant that into a description of how something is functioning, how something has functioned, right? That might be a little bit aloof. Anyways, the thing that I'm going to read first from is Ernest Eckford Tucker had typed up some reminiscences. If you look on the Museum of Osteopathic History's website and you go to their online collection, this is the first one under the Charles E. Still collection, because he sent it to Still. The second link under the Charles E. Still collection, I think, kind of goes nowhere, but that might have just been the time that I looked. But anyways, the first one under the Charles E. Still collection is the reminiscences of Ernest Eckford Tucker. What I'm going to do is read something very specific, and then I will read something from Dr. Still, and I will read something from, I believe it's Hazard. I think it was Hazard's class notes. There's 2 volumes of Charles Hazard's class notes from 1898, right? It's very, very early on in the first volume. So I'm going to first read the stuff from Tucker, then I'll read the stuff from Still, then I'll read the stuff from Hazard, and the point is to look at very, very early on in the osteopathic profession, when Dr. Still was heavily involved, the types of things that he would say and the types of approaches he would advocate one take, even though when you read his books, especially Research and Practice, you will see him pointing at particular conditions and, I would do this, I would do that. Because by the time he got to Research and Practice, he had written 2 previous books on osteopathy, so Philosophy and Philosophy of Mechanical Principles, and they're, long soliloquies about anatomy and just his rationale with no technical instruction, but Research and Practice has some technical instruction. I will say that the technical instruction in Research and Practice is usually missing what I would consider very, very important details. Like he would say, stand on the side opposite of wherever you find the problem in the neck, but he doesn't tell you if you're standing at the head of the table opposite or if you're standing on the side of the table, say, inferior to the neck. He doesn't inform you of these things, so you have to infer or experiment. Now, that's just partially the nature of writing technical descriptions. So descriptions of technical movements between 2 people require a lot of words, so it's really easy to either be convinced that you said everything you need to say or wanted to say, or just make the error and leave it out because you're pretty sure you left it in there or you had it in there. Anyways, to read from Tucker. On one occasion, I was seated high up in the amphitheater watching dapper Billy Laughlin draw sure and swift strokes some anatomic charts on the blackboard. From where I sat, I could command a view of the door, and out of the corner of my eye saw a shadow darken it. Dr. Still, as silent as an Indian, had stolen in and stood there, watching and listening. Now, I want you to remember that this is written in 1951, and the event itself would have been the very early 1900s. So the term is referring to Native Americans, but this is from historical documentation. So hopefully the term isn't a nuisance, but that is the term that was used. To continue reading. Somebody spied Still, and seeing the loss of attention, Laughlin turned and saw him too. He promptly stepped aside, of course. Still came in on tippy toes, as always. So to pull out of the reading, apparently Dr. Still liked to walk on his toes. He did have high arches, and when the Museum of Osteopathic History was deconstructing his boots, or so not really deconstructing his boots, trying to make replicas of his boots, they found that Still had inserted orthotics, but what they were for was to actually drop him to the medial side of his foot. So they attempted to take the outside of his feet and put them higher so that it would essentially flatten his arch out or make him walk more on the medial side of his foot. But apparently he walked on his toes. So again, to keep reading. He took stand back of the desk, leaning on his long staff, and looked the class in the eye, silent. Then he smiled and chuckled, and the class chuckled back at him, looking for what was funny. This is not easy to do, by the way, if you happen to have ever tried it. Boys and girls, said he, I'm going to draw you a pig. And again he chuckled, and the class obligingly chuckled back. Still then turned to the blackboard, and with a piece of chalk drew something rather like a pig at first, but soon developed a long peaked neck and 2 long legs and a fan-like tail. Again facing the class, he chuckled. Then again the class kindly chuckled back. To pull out, again, of reading, one of the things that Dr. Still did, apparently, is when people would come to his house, he had sort of a guest book, but it wasn't really a guest book. What it asked you to do was look away and draw a pig. So draw a pig while not looking at the page, and then after you did that, you would put your name under it. And Dr. Still did it too. I don't remember if I've directly seen it or I've just seen images from it, but the Museum of Osteopathic History does have that in Kirksville, does have that actual book where people would look away and draw the pig. So for some reason, Dr. Still had some interest in people drawing pigs for fun. So anyways, to come back to read. Suddenly, he drew himself up and his mood changed as though under a thundercloud. How many of you diagnosed that thing as a pig? He demanded. The class was suddenly very quiet. He threw down his chalk. Then after a pause, he went on. You read in your textbooks that pneumonia is such and such and so and so. Maybe it is, but you look for yourselves according to osteopathic teachings and see everything, not just what the book says. I never fail to find, and my graduates never fail to find, such and such a condition in the body. It is a turkey, not a pig. You will never find it if you never look for it, but if you look for it, you will find it. If you treat the case according to what the book says, you will get the result that the book promises you, which is not much. If you treat what you find as osteopathic physicians, you should be able to cure your case. To continue reading again, so clearly I've been reading, but to make sure that you know that I'm still reading. What is osteopathy? You examine the body as an engineer, and the body itself shows you what to do, what needs to be done. You treat what you find. If you go to consult different authorities, you will get only confusion. They do not agree, their results are not good. They do not know what is right or if any of their measures are right. Okay, so long story, or I read it long, it's not that long. Dr. Still, by analogy, tries to show that if you have an idea of what something is before you examine it, you will probably not interact with it appropriately in the moment, trying to not say the same word twice in close succession. So if you examine something properly, you will likely find appropriate solutions. If you examine something, or if you approach something as if you know what it is before you check it, you will likely not find the appropriate solution. You will overlay the solution you were told to put on it, and then maybe it works, maybe it doesn't. So he talks about stuff like this as cut and try. I would argue that hands-on manual treatment does have, it's a hypothetical deductive approach. So you find something, you make a hypothesis that if you work in this way, it will change, and then you re-examine it. It either has changed or it hasn't changed. If it hasn't changed, you try again in a slightly different manner or a dramatically different manner. But to not include the hypothetical deductive method as describing osteopathic manual therapy would be disingenuous. Anyways, Still is saying don't look at the descriptions from the books as if it is what you will find. Across time, when reading old osteopathic literature, I've had the experience that people display some awe or some amazement that look at what they treated, look at what they treated, look at what they treated. If you look at their recordings, the ability to have confidence that they did what they said they did is low, right? You're just not finding much as far as what happened to those cases, especially with the manner in which they were able to measure things or observe things or record things. So lower confidence in them saying, I treated pneumonia, I did this, I did that, right? Either way, Still is noting very explicitly in this story, written in 1951, he died in 1917, So there's a long distance between when this would have happened and when it was written, but it was obviously a strong impression on Tucker. So you can question the accuracy of the story in its fullness. There may be some things a little off, but the general gist is examine like an engineer, aka test what the body is doing. Whatever the body is not doing appropriately, that's what you work on, according to this story from that is describing what Dr. Still said. Okay, so now to switch over and to read something from Still himself. Okay, so this is from The Philosophy of Osteopathy, which is the first technical book that he wrote. Well, not the first technical book, the first osteopathic book that he wrote. The first book he wrote was his autobiography, then he wrote Philosophy of Osteopathy, then he wrote Philosophy of Mechanical Principles, then he wrote Research in Osteopathy, Research and Practice. So to read this, this is likely from the foreword of Philosophy of Osteopathy, and this is directly from Still, at least in written word. It is my object in this work to teach principles as I understand them and not rules. I do not instruct the student to punch or pull a certain bone, nerve, or muscle for a certain disease, but by a knowledge of the normal and abnormal, I hope to give a specific knowledge for all diseases. So he was hoping to teach in the abstract. He was hoping to say, if you find something not doing what it should do, that's what you'll work on. And then what I would suggest is post hoc, after the fact, Still would have tried to connect the thing that he did, the condition that it likely was, and the anatomy. So he probably tried to describe it anatomically based on what he found, what the condition was, and how it changed. So that's the method of reasoning or the method of describing after the fact, but it wasn't necessarily what he did. His method in interfacing with human beings that came to him for treatment was find what's not moving, work on that. Whatever happens is what happens. So find it, fix it, leave it alone. Nature will kindly take care of the rest. Okay, so again, at least we have some level of the message being mirrored between what Still wrote in Philosophy of Osteopathy and the story as told by Tucker. If you look at the general content of Philosophy of Osteopathy and Philosophy of Mechanical Principles, again, there's a lot of talk about anatomy and no technique. He gets to the point of research and practice and he has to give some technical description, but that technical description, I would say, is quite wanting. So I don't know if he made it that way on purpose. I don't know if he thought it was a really full description because he preferred to write in the abstract and philosophical. I'm not sure. I can't comment on that, but I can say that the technical descriptions aren't that fun or useful. Now I got to go way down to read something from Hazard. It's just in a different part. There we go. Okay, so this is Charles Hazard. So this is from the volume 1 of his Charles Hazard's lecture notes from 1898, and I will read this. So lecture 1, this is right at the beginning. General considerations. Learn to treat understandingly. Imitate no operator's motions. Emerson says imitation is suicide. Take, for instance, a case of erysipelas. I may be saying that wrong. Should the operator treat about the sore spots occurring usually on one side of the face near the ear and treat there alone without giving attention to the general conditions of the patient, taking into account the affections of the kidneys, liver, and other organs. In this trouble, he would certainly not meet with success. One must understand the nature of the disease which he is treating. Continue reading. Next paragraph. Make a correct diagnosis of the case. There are no two cases alike. You cannot take it for granted that one case which you receive today is like the case you treated yesterday. Look over the case thoroughly, making an individual diagnosis for it. Likeness and unlikeness to other cases are incidental only. Make no diagnosis by telephone, as I knew a physician, a fellow townsman of mine, to do once. Remember, this is 1898, he's talking about telephones. Remember that a young doctor's success often depends on how he handles a simple case. Reading further, I don't need to read the rest of that. I will read the final portion of this page. Have your theories, but stick to facts. Remember that you cannot always treat a case according to preconceived theories, that each case is peculiar to itself. Huxley says, theories do not alter facts, and the universe remains unchanged even though texts crumble. Okay, so fundamentally, the message there is, again, the same message. Check out the individual that is in front of you You can have preconceived ideas that maybe get you into the general range of thinking about something, but the facts of the case or the observances of the individual may not match those preconceived concepts, the ideology, the idea that you're importing. So you have a really hard time when you're trying to get to the right details to pull into the case. At least in osteopathy or hands-on manual therapy, you have the great benefit of interfacing with how that person moves. And if that is why they're having or they're reporting the sensation that they're reporting, then it will change in some degree related to the fact that you've changed the motion, because they're appropriately related. But there are definitely times when that's not the case. So the overarching message very early on in osteopathy, from Still, from Tucker talking about Still, from Hazard in 1898, first class was 1892, so this is very, very early in the osteopathic profession. But then when you go on to read the rest of the class notes from Hazard, it's talking about very specific conditions and the anatomy and whatnot. So he starts off by saying, hey, check out the individual, make sure that even though, yeah, sure, you'll find stuff around the side of the face, then make sure you check everything else too, right? He's saying that, but then he has to give lectures on very specific things. Still had to do the same thing, but he was very reluctant to talk about the technical interface. The thing that I think is exceptionally important is that I had been aware of a lot of this information very early on in my osteopathic career, my osteopathic education. I've been able to go back and look at it again. My sense as an individual is that the heuristics that I developed were definitely informed by things that I knew, but not necessarily specifically pointing to any one reference or resource. So, macro identifies micro. Big movements are made up of smaller subcomponents, and if the big movement isn't working right, you can usually see where it's breaking down, so then you can zoom into that smaller part, right? That is the way that I will teach students and teach osteopathic practitioners to handle how to figure out where to go. You do big movements, you figure out where to zoom in more. When you zoom in, you find the more fine-grained stuff and really work on that appropriately. But it's so that you can find the area that's not moving effectively and work on it effectively, as opposed to the person said these words, which likely means it is this thing, so what do I do for that thing? Because if I treat the condition that they note, if somebody says, I have sciatica, if I do the sciatica treatment, I have failed to examine that individual, and I will maybe have a positive impact, maybe I won't, I'm not sure. But if I examine that person who says the word sciatica and I find where things are not moving, then whatever it is about the uneven distribution of load that could be impacting that sciatic distribution should change. And if that's why they're having that sciatic aggravation, that sensation should change. If it's not why, then there may be something like neural pathology or neural inflammation, and it would be differential diagnosis through treatment. But if I do the sciatica treatment, I could aggravate the sciatic nerve, I could miss everything that's going on with that particular individual, or I could do a fantastic job, but it's all more or less by accident because I didn't examine the individual in the moment. So the message that I try to provide is that you need to check that person. Where do you treat? Wherever it's not moving. That's the answer. The answer is always where it's not moving. Now, if we move over into the land of physicians, it's different. The amount of details that they need, the amount of details that they're working with, the level of stakes in many cases are much higher. There's much more danger inherent to being a physician than to being a chiro, to being an RMT, to being a physio, to being an osteopathic manual practitioner, whatever hands-on practitioner we want to talk about. The risk profile is much lower. So our clinical reasoning can be much more straightforward. We're just looking for where it's not moving. We're not treating conditions. It's also partially why the legal system in most locations says you're not allowed to even talk about the pathology, right? Or identify a pathology and name it. You're not allowed to diagnose. And it's because our interventions are not targeting the signals of those things. So let's just say you think there might be an infection, right? You don't know for sure that there's an infection. You can have a really, really good idea, like say something's very red, very hot, and there's kind of red streaks going away from the area. You're like, I'm pretty sure those are good superficial signs that there's an infection. But you can't necessarily target it because the process in and of itself isn't likely amenable to manual methods. You probably need something that would target that particular bacteria or virus, right? Like you would need something accurate for that. We can't do that. Hands-on therapists, unless they have unlimited medical licenses, such as Doctors of Osteopathy in America, can't interface with that. We can't target it because we can't get the proper information that tells us what would be useful to do about it. So our rationale, rather, our clinical reasoning, is a much more simple thing. Just find where it's not moving, do a really good job with that, respond to how that patient responds to your intervention. So if the patient jumps, if the patient's very abrupt, or abruptly responds to what you do, you did it wrong, at least osteopathically. So do it a way that they don't have that protective response, right? So it's a much more straightforward approach to clinical rationale, clinical reasoning. And I'm comfortable saying that at this point. It doesn't mean that there isn't more complex things that happen with hands-on treatment. It just means that your ability to identify and target them are low. And the net message that it seems like we're getting that is consistent is, although you will find osteopathic books that talk about specific cases or specific disease processes and what you might find because of, previous experience or anatomical relationship, they often say, treat what you find, not what you think you will find or what somebody told you you should find. You need to treat the individual in front of you. So thank you for listening this far. Hopefully you've learned something, and we'll talk again soon.